So what do you do if the patient presents with symptoms of early Lyme disease but no memory of a tick bite? Well, as I've told you before, the tick is the size of a Sesame Street seed. It might be bigger if it's engorged. Patients don't very often remember the tick. But if you see a rash that is consistent with ECM, the erythema chronic migrans rash in a farmer, that is diagnostic of Lyme. It's a clinical diagnosis. Just like when you look in somebody's ear and you see a red ear and the eardrum doesn't move, that is diagnostic of an otitis media. You would treat such patients. Similarly, if you have a rash that is consistent with Lyme disease in the right setting, you should automatically treat patients. Sometimes the rash is atypical, and that can be more of a challenge, but don't get caught up in the idea that everybody must have a rash and the rash must be the typical bullseye rash. Number two, if you have a rash, even an atypical rash, and you have multiple new symptoms that patients didn't have before, that is clinical evidence that the bacteria is in the process of disseminating. Lyme is a spirochete that spreads from the skin, migrates through the blood. Sometimes you get flu-like syndrome, and then you have multiple different manifestations, multi-organ involvement. So I think it's really important then to be aware of flu-like symptoms, fatigue, headache, neck ache, myalgia and arthralgia. And in that situation, the guidelines say treat. Current NICE guidelines say treat for 3 weeks with antibiotics, and if patients still have symptoms, swap to an alternative for another 3 weeks. So I think it's really important to understand once again that Lyme is a clinical diagnosis, and a rash of Lyme is pathognomonic, but the rash is not always classic.